Welcome to the Roche Idea Lab. Please welcome Angie Howard and Angela Baldwin.
Good afternoon and welcome back to the Roche Idea Lab. The Idea Lab is a community where we come together to discuss the challenges that we face as an industry. My name is Angie Howard.
And I'm Angela Baldwin, and we're your hosts for the Roche Idea Lab. I'm a board-certified anatomic pathologist. I've been working as a pathology liaison in the Medical and Scientific Affairs Division at Roche since April. I work closely with other members of our internal Roche team, and it's a very collaborative role, where I have the opportunity to educate and learn from internal and external partners. Angie?
And I'm the Roche Business Manager for our molecular franchise in the Midwest. I have 20 years of healthcare industry experience, 12 of which have been working here at Roche on many cross-functional teams. In my role, I have the opportunity to work directly with healthcare executives and laboratorians regarding the challenges that they face most. We're both really looking forward to hearing the ideas that you have to bring to the table today, as well as the insights of our guests that we'll have on stage. Antibiotic-resistant bacteria and fungi cause more than 2 million infections a year and more than 35,000 deaths. Antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by physicians and how they're used by patients.
Partnerships with labs is crucial because diagnostics play a key role in stewardship. Here to take us through the importance of lab and clinical workflows and mitigating use is Dr. Larissa May and Jamie Dieter.
Good afternoon, everybody. I'm absolutely thrilled to be here today with Dr. Larissa May from UC Davis to talk about antimicrobial stewardship, interventions that can impact patient care and can aid healthcare providers with using the therapies that we have available in an optimal fashion. So Dr. May, it's safe to say that you are an expert in antimicrobial stewardship. You have spent the last several decades with your research, with your publications, advocating for antimicrobial stewardship. Through this passion, I know and recognize that you've been able to collaborate with industry, with the CDC, different institutions, and so you do have disclosures today that you would like to share. So they're listed here, but I think what we really want to know is, how did you become this expert in antimicrobial stewardship?
Well, thank you so much, Jamie, and I'm thrilled to be here to talk about one of my biggest passions. So antibiotic stewardship, as was mentioned previously, is the optimization of antibiotic use, and we'll talk a little bit more about that. But I can say, infectious diseases have always been a passion of mine. So when I was a medical student, I actually thought I wanted to be one of those virus hunters, that chases after Ebola. And I pursued an internal medicine residency at first, but along the way, in November of my intern year, I did an emergency medicine rotation, and I absolutely loved it. I really liked the fast-paced, I liked the differential diagnoses, I liked treating patients across the continuum of care, including infectious diseases. And so I was fortunate to be able to switch to our emergency medicine residency. But in that process, I always kept my interest in infectious diseases. So when I finished my residency, I actually completed a Master of Science in Public Health Microbiology and Emerging Infectious Diseases. And then in 2008, as I was an early faculty member, I had a new mentor that had moved over from Pittsburgh. She was a molecular and clinical microbiologist, and she was really instrumental in introducing me to the idea that rapid diagnostics could really help improve the management of patients in the emergency department. And so I began a career development award under her support. And my first project was looking at the use of rapid MRSA diagnosis for patients with skin and soft tissue infections in the ED. I went on to do other diagnostic studies, but along the same time, antibiotic stewardship wasn't really something we were talking that much about. So infection prevention, was very commonplace then. That was sort of what the hot topic was. And I had a sponsor at Hopkins, Sarah Cosgrove. Maybe some of you have heard of her. She's really a world-renowned expert in antibiotic stewardship. And she and I had a conversation. And she was instrumental in really helping me realize that the emergency department was an untapped setting for antibiotic stewardship. And I know we'll talk a little bit more about that. In 2015, I was recruited to the University of California, Davis to start a clinical and research program in ED antibiotic stewardship. And then that role eventually expanded to include all of our outpatient health system. And I also became the PI of a CDC-funded contract to study an intervention or pragmatic trial to reduce inappropriate antibiotic prescribing for upper respiratory tract infections, which was sort of the low-hanging fruit in 9 emergency department and urgent care settings. And that project was really successful, but what I'm most proud of was that we actually developed a toolkit or implementation guide to help other folks across the nation to implement antibiotic stewardship programs in the ED and urgent care setting. And that work has since expanded to include other hospitals like University of Washington, as well as Eisenhower Health in Southern California. It's been recognized by SHEA and the CDC. And so I think that was the crowning moment, really, of my work. And so I think from that moment on, I really have served as the emergency medicine national expert. And I'm happy to say that emergency physicians have finally come along. And I've now had the opportunity to work with the American College of Emergency Physicians for a bedside toolkit that's really meant for clinicians in the emergency department to kind of have those principles of stewardship and pitfalls of stewardship right at their fingertips. So very excited about how far this has come along, when it wasn't even really a thing back then.
Right, yeah, absolutely. You mentioned diagnostics play a role, and when I look at your publications, though, it's more than just diagnostics, it's more than just education. There's core components, and then there's behavioral components that you talk about. But before we really dig into these interventions, I want to know, how do you define antimicrobial stewardship?
So I think antibiotic stewardship, and those two terms are pretty much interchangeable. Of course, on the hospital side, we sometimes focus on other antimicrobials like antifungals or antivirals, but really in the emergency department, the mainstay is antibiotics. So just to be simple, let's just call it antibiotic stewardship. And that's really optimizing antibiotic use. So getting the patient the right therapy, so the right antibiotic at the right time, for the right indication, the right dosage, and the shortest duration possible for effective treatment. And the goal of this, of course, is for patient safety, because stewardship is at the intersection of patient safety, infection prevention, and public health. So we do want to focus on the downstream benefit of reducing that antimicrobial resistance that we talked about, but also really it's more of a patient safety issue in terms of the patient outcomes. And in many cases, for example, presumed viral respiratory tract infections, that will mean no antibiotic at all.
Right. Patient outcomes are paramount. We know that the CDC estimates about 36,000 deaths annually due to antibiotic-resistant bacteria. And so that's the why. Why is this so important to you? You mentioned patients, but at your institution, why is antimicrobial stewardship at the forefront?
So I think UC Davis was very forward-thinking compared to many institutions at the time. Now, 2015, California was already talking about legislating antimicrobial stewardship in hospital settings and long-term care facilities, which I believe happened ahead of CMS even really making it, one of their components of JCO, or one of the components of JCO certification as well. So we were kind of ahead of the game. It was the right place to do this kind of work. And I think, at the time we were having some, shall I say, challenges with Clostridium difficile infections in our hospital. And there was a big focus on expanding our infection prevention team. And I think, both our hospital epidemiologist and our chief quality officer really saw the value of stewardship in that prevention of Clostridium difficile. And knowing that, if we don't focus on the outpatient side, where most of our antibiotics are actually being prescribed, then we're not really comprehensively addressing the hospital setting as well. So there were some incentives, but I think it was just more that focused on the value that this could provide to the health system.
Yeah, your CDC grant, it was multi-site. You studied 5 different EDs, 4 urgent cares. When we look at antibiotic prescriptions and where they're written, typically in the ED, I think the estimate is around 10 million annually. Antibiotic prescriptions come from the emergency department. The CDC actually estimates that about half of these are unnecessary or inappropriate. So there's definitely an opportunity in this setting. And, I don't call that out because there's many settings that, there are these opportunities that exist. But you do practice emergency medicine. And so your research is here. So talk to us specifically about the approaches that you found beneficial within the ED to aid with stewardship.
Yeah, so there's a number of potential approaches for antibiotic stewardship, but there isn't really a one-size-fits-all in the sense that whatever works in the hospital setting is not necessarily applicable to the ED. And I think the greatest opportunity, given that the vast majority of our patients, even in a quaternary referral center like ours, are still discharged. So there's really that opportunity at the transitions of care that I think sometimes has been lacking in hospital antibiotic stewardship. But there's been a number of approaches. I hope every hospital at this point has an antimicrobial stewardship committee. And so, having ED clinicians be part of that committee, we're always shocked at how many hospitals don't invite their ED clinicians there. And typically that's a place where the lab is, the hospital epidemiologist is, the pharmacy is. So it's a good opportunity for multidisciplinary collaboration. I think there's some other tools. Education is important, but as I'll talk about later, antibiotic prescribing is often a behavioral problem, so education alone can only go so far. So for example, I think about 98% or more of physicians know that we shouldn't prescribe an antibiotic for acute bronchitis, and yet it still happens. We're all guilty of that in the ED. So why? So education alone, it's important, but it's not the only solution. Also, our specialty societies in emergency medicine typically don't put out their own guidelines. So there's a lot of interest and a lot of skepticism, frankly, at other society guidelines. I think that's changed with the COVID pandemic, but if all the guidelines are coming from ATS, IDSA, like the American Urological Association, it's really helpful for ED clinicians to have a champion on board on the ground and really to tailor those guidelines to the local site and setting. So that's another thing that can be done. I think we have an opportunity for clinical pathways, but again, there's that behavioral piece. People may not use the order set. I think we are getting more sophisticated with digital health and clinical decision making tools. I'm very interested to see where machine learning goes in the future. And then obviously rapid diagnostics are really the cornerstone of the IDSA strategy to really improve antimicrobial stewardship, and that applies to the ED, I think especially.
Absolutely. I know that UC Davis made a decision to put the Cobas Liat, so that's a rapid PCR. You can get a result within 20 minutes and it's CLIA waived, so it can be utilized by untrained users. You guys decided to implement this not only in the ED, but outpatient clinics too. Can you talk to us about your decision and the factors that went into kind of choosing this instrument and where to put it?
Yeah, so I think the benefit is that the lab, certainly my lab collaborators could speak more about this, but the lab was sort of being revamped in terms of automation and thinking about solutions that could really fit into our point of care program, but really add additional value. So having a molecular system was going to be much more accurate and with the turnaround time much more useful in real-time clinical decision making. So we in January 2018, so pretty early on, we implemented, as Jamie said, the Cobas Liat, and by the end of January, I believe we had 26 instruments in place. At least 2 of those were in the ED, and then the rest were in our outpatient clinics, and since then we've expanded, so we have one in the cancer center, one in our off-site pulmonary clinic. So it's been really useful to reduce unnecessary prescribing and really be part of our outpatient antibiotic stewardship program. In fact, I can share with you, recently in OFID we published the results of the Liat implementation for Group A strep, for the Group A strep assay, and so we reviewed in a retrospective quasi-experimental pre-post intervention study more than 10,000 patient records from our outpatient system, and we found a 44% reduction in antibiotic prescribing during the visit for those patients with a negative POC test. So that was from 18% for our previous rapid antigen test down to 10%. And so that was pretty surprising, because obviously diagnostics aren't the only solution, but I think it really illustrated the limitations of rapid antigen testing, where we had the reflex culture going on thing, and so people often wouldn't trust that the result was actually negative, and so they would go ahead and prescribe empirically. So that was a successful implementation of the Liat system. And since then we've implemented the COVID flu assay, and we're in the process of evaluating that implementation.
Sure, and pre-pandemic empiric diagnosis with influenza-like illness has an accuracy of around 30%, right? So we know we want to do better than that. And I was excited and motivated to see the percent change that we saw at your institution. I know also pre-pandemic, you had started a study looking at the LEOT and also a core lab product. When we think about respiratory pathogens and the need to test and have that answer immediately, we know it is vital coming, hopefully out of this pandemic soon, and knowing that we're preparing for respiratory seasons. I'm hesitant to actually say the word season because with flu last year we saw an elongated season, albeit very low % positivity. We saw sporadic outbreaks with respiratory syncytial virus. We know that because of the non-pharmaceutical interventions that were put into place to prevent the spread of SARS-CoV-2, that these pathogens haven't been circulating in a normal fashion. And so there's a larger group of the population that might be more susceptible due to that length where they haven't been exposed. So I know healthcare providers are really trying to get ahead and think about, what does this next respiratory season look like? We often prognosticate by looking at the southern hemisphere. And so we are expecting to see a high burden of flu this year. So your study, though, it was at the point of care for flu, and then you utilized PCT or procalcitonin. And so this is run in the lab. Talk to us about, one, what is procalcitonin? How does it fit in the antimicrobial stewardship puzzle? And then what was the design and the intent of your study?
Yeah, so this, now we're kind of moving on to more lab-based solutions that could still be on demand and valuable for the ED team and clinical decision making. So there was a large body of evidence from meta-analyses that PCT or procalcitonin, which is a biomarker that can, not completely reliably, but can aid in distinguishing, perhaps viral versus bacterial infections, particularly have been used for undifferentiated sepsis and also some for lower respiratory tract infections. And I'll talk a little bit later about how we designed the workflow of this study. But essentially, we had this idea that stewardship in context, the situational aspects of stewardship really matter. So having implemented our stewardship program and then expanded it, by that time we started this study, which I believe was like 4 flu seasons before we actually completed it, due to some delays thanks to COVID. That we really thought, well, perhaps having a pharmacist-guided intervention in real time, in aggregate with point-of-care testing for influenza and RSV, plus this PCT, could perhaps make a difference in helping clinicians actually accept or trust the value of a PCT, and then be able to use it in real time to make decisions around antibiotics and hopefully reduce unnecessary antibiotic use.
Yeah, and it was challenging. I think a lot of us experienced the impact of the pandemic on studies. So, although it wasn't perfect, was there anything that you were able to conclude from that study?
Yeah, so we had randomized patients essentially under 50 years of age to the arm the intervention with the PCT, the plus minus point of care testing, plus the pharmacist intervention. And we were limited, obviously it was a small sample size. We were limited to when our pharmacists were actually available, and we did not have at that time 24/7 pharmacy coverage. We now do in the emergency department. And knowing that this trial had come out like a few years ago that you can see up there, which had based on all the evidence from the meta-analyses, thinking that this would be just like the solution to reducing antibiotic use for patients with presumed lower respiratory tract infection. I think this study, which basically was a randomized control trial at the patient level in 14 U.S. hospital emergency departments, but the patient population, in my view, was not the right population. And this really illustrates how important clinical workflow is because they were all patients being admitted to the hospital for pneumonia. And so once a patient's being admitted to the hospital for pneumonia, the decision is already made that the patient has community-acquired pneumonia. So adding the PCT is too late in that process. And so that was one point. The second point was there were different assays with different cutoffs that were kind of confusing for the clinicians in a lot of these hospitals who'd never been exposed to PCT and frankly might not have trusted it. And then it was not in the context of stewardship. So I think, even though our study, because of all the challenges, I believe, failed to show a difference between usual care and this intervention, we did do a post hoc analysis evaluating the use of PCT, because what happened is as the pandemic came on board, a lot of people just started sending PCT, and my chair, Nathan Cooperman, who is a very well known and regarded pediatric researcher, has done a lot of work on febrile infants and PCT. And so at least for our pediatric patients, it sort of started being sent routinely. And as many patients were sicker during the pandemic, a lot of these patients were being hospitalized. And so ultimately what happened is the post hoc analysis did show good results, that clinicians did seem to be more likely to prescribe antibiotics when PCT was high and less likely when it was low. So suggesting that there was an impact on clinical decision making. So that was pretty exciting. But I think the reason we designed the study, to get back to what I was talking about before, the way we did is because of the failure of this implementation in the New England Journal trial. It wasn't a failure of PCT. It was a failure to consider heuristics and sort of the automated thinking processes that clinicians have. So I think we all like to think about how clinicians are very deliberate and thoughtful in their decisions, and they use deductive reasoning and they're very rule-based. But the reality is, the brain is trying to be efficient, and so we don't actually think like that. It's more experience-based, semi-automatic, uncontrolled, effortless. It's how, when I was younger, I hate to admit, I used to drive home from a night shift and end up in a different neighborhood. And not know how, which is kind of scary, right? But it might have happened to you if you're planning to go to the grocery store on a Saturday morning, but you get on the freeway in the opposite direction because that's the way you usually go to work. That's sort of an example of that. How learning how to drive is really hard, and you have to pay a lot of attention. But once you drive, it becomes effortless. So I think it was a failure to consider how ED clinicians actually think and to really implement that testing before the decisions were already made in our brains, and considering both laboratory as well as clinical workflows.
Yeah, and when we often talk about this, you mentioned this book, Thinking Fast and Slow.
Yeah, that's one of my favorite books. I mean, if you haven't read it, and Daniel Kahneman has a bunch of other great books, but I think it really illustrates how an ED physician thinks. So the first time I read this book, I was like, that is exactly me.
And something else you often talk about, and it's evident in the publications, is it's an iterative process, right? So it's what works in one setting might not work in another setting. You might have to move forward and plan and then review what's working well and then pivot. So how have you done that at your institution?
So I think a lot of the recent work I've done, I agree, there's not a one-size-fits-all approach. You can't just take what you do in the hospital and then stick it in the ED. You can't just take what works in an academic hospital and then translate it to a small community hospital or critical access hospital. So this is really, what's shown here is the IHI model of quality improvement, which is basically the Plan, Do, Study Act, but we've taken it to a different level. So the CDC study, we actually used implementation science methods, which basically are designed to apply accepted evidence, so like tools that work, and then apply them to the local context and setting. So basically you end up guaranteeing success of your intervention. And so that's an approach I've taken. It's a little more labor intensive. It does require additional expertise, but you can take parts of it, which basically, you have you really want to get your champions and stakeholders involved earlier in the process. Have like a little bit of a pre-implementation like run-in period, which I think a lot of hospitals with all their incentives and timing sometimes doesn't work at all. But we've tried to take that approach so that we can really be thoughtful about how we implement these interventions. And then, sometimes we have to pivot. Something's not working. For example, we were trying to apply evidence in this CDC study where, the CDC had put out these, commitment posters, and we thought, oh, this is great. We can put all these commitment posters on the walls, but then, different providers on different shifts see patients at different times, and there's not really one place where patients can see this, maybe the bathroom, who knows. But, getting all these ED clinicians to sign this, we had to make some modifications. And some examples of that is we actually had flair in the way of badge reels and pins that would just kind of serve as a visual commitment or reminder to patients and providers that we really weren't going to prescribe antibiotics unnecessarily. And I think, the nice thing about that is that those techniques that use these nudges or sort of like reminders, or they're non-intrusive persuaders, basically, of changing your behavior when you don't really feel strongly one way or another. So not going to work, for people that are adamantly opposed to vaccination, but works pretty well for, a clinician who might be thinking about prescribing a Z-Pak when they don't need to. So we did make some modifications there, and the nice thing is that those interventions have actually been sustainable over time.
Yeah, who doesn't?
Even though
like
the posters
Flair?
are long gone, and
Yeah.
the flare is who knows when.
Well, when we take a moment though, and we kind of look back at the early year, 2020, the pandemic, we know that the CDC has estimated between March of 2020 and October of 2020 that about 80% of the individuals that were admitted to the hospital for COVID-19 actually received an antibiotic. And we know that antibiotics are not effective against viruses. We also know that, just because you have the presence of a virus, it doesn't rule out a co-infection with bacteria. But it's thought that the pandemic, it essentially made all of our antimicrobial stewardship efforts take a step back. What are your thoughts on that? What would you say to that?
I think that was definitely true at the beginning, since honestly, we as clinicians, we were scared. We didn't know what we were dealing with. At that point, a lot of the patients were coming in quite ill. We had limited testing at the time. There were no treatments at the beginning of the pandemic other than supportive therapy. And so I think, especially for those patients coming into the ICU, definitely the knee-jerk response was, let's prescribe the broad-spectrum antibiotics. Now, I know there's also evidence that even in the outpatient setting, I saw some early studies from South Korea and Spain that also, like, for example, the use of azithromycin went up exponentially, at the beginning of the pandemic. I think over time, there's been a renewed interest and effort on antibiotic stewardship, recognizing some of those patient safety issues, the risk of adverse events, the antimicrobial resistance, how so many of these patients were in the intensive care unit, that I think, things like PCT did actually help, when patients would come in and they had viral pneumonia, and we're looking at this x-ray and saying, is this atypical pneumonia? Is it a co-infection, or is it, just COVID pneumonia? And I think over time, especially when we'd see these, at least most of these patients initially had low PCT values. I know that they don't necessarily stay that way when the patients are hospitalized, but I think we started to become more comfortable perhaps with withholding antibiotics. And if nothing else, I think patients finally know what a virus is. So that was particularly helpful also in terms of being able to explain how we manage viruses and why antibiotics don't work. Of course, there was still the occasional patient who, would tell me, but my boyfriend who has COVID just got an antibiotic. Why can't I get an antibiotic?
Right.
So I think that the things that have changed really is, we do have better treatments now.
Sure.
We are focusing again on stewardship, and this whole role of diagnostics and the test to treat strategy is like so important, and probably has application to other diseases in the future, like RSV, certainly influenza. So I'm actually excited to see that, diagnostics finally, people kind of realized their importance, which maybe, was a little bit of a struggle a few years ago.
Yeah, they definitely are a piece of the puzzle for sure. And so the last question I'll ask you today is, as we look ahead, we're in this COVID era now. What are the opportunities, what are the challenges that you see for driving an effective antimicrobial stewardship team at an institution?
Yeah, so I think the challenge is, always going to be being asked to demonstrate that return on investment, which is not necessarily easily calculated in terms of monetary value, but we do know that over time, we can decrease complications in our patients. We can preserve the antibiotics we already have, not just as a society as a whole, but even individual patients who receive multiple courses of antibiotics will get increasingly resistant infections. And so there are obviously other areas to focus on, like asymptomatic bacteria. I would love to see, a better test that can really help support clinical decision making there. I guess we're not quite there yet, but I think going forward, we do recognize that stewardship is important. I think a lot of societies, certainly the payers, are recognizing that it's important, and so there's an opportunity to collaborate with all the entities that have a stake at this, and really, as I said, 15 years ago, when I started in this field, as a passion of mine, it was really just, it was an opportune time for this opportunity, for lack of a better word, to really practice stewardship in emergency medicine, but it wasn't even until the last, I would say, 3 years that I was actually recognized by my own colleagues as doing this work. I think infectious diseases and microbiology and others were realizing it, but I think there's now a real opportunity with the pandemic for all of us to collaborate, for the laboratory and the emergency department and the outpatient clinicians and the ICU and the payers and the government. It's kind of, healthcare is dynamic and very complicated, especially in this country, but I think this affords us a unique opportunity to not forget the lessons we learned from the pandemic, and for the next thing, be it monkeypox or any other thing that's coming around, let's not forget about stewardship too.
I couldn't agree more. So we do have time for some questions to continue this conversation with the audience. Any thoughts, comments, questions? You have microphones at both the ends. All right, if no one has a question, I'd like to thank all of you for joining us today, and thank you so much for your time and all the research that you do in this area.
Thank you. You've been a great partner.